Next up, I'm hoping should be, I can't see him on the screen at the moment, should be Joe Allen to talk to us about a NatSSIPs workshop and sort of a gap analysis. And Joe's coming to talk to us from the Suffolk and North East Essex ICB. So Joe, welcome, and over to you.
Great, thanks very much, Ian, and thanks for inviting me today. I'm going to share my slides, so hopefully you can all see those. So please let me know when you can see them. Great. Okay, so yeah, this is a great. We held a local workshop in our ICB in Suffolk and North East Essex in May 2023 on NatSSIPs 2 and procedural invasive safety. So I wanted to just have an opportunity to talk that through with everybody on the workshop today. So this really, the origins for this workshop really were that with ourselves at the ICB noticed that we'd got a high amount or a significant amount of never events that were reported across our 3 acute hospitals in Suffolk and North East Essex. And our highest never event classification was for wrong site surgery. And obviously we wanted to do something as a system to try and improve from that position and reduce the number of never events. And we originally decided that we would come together and do a focused workshop on never events, but the more that we started talking about it and discussing it, the more we realised that the better thing to do would be to focus on the NatSSIPs 2 agenda and implementation of NatSSIPs 2. So that became our approach. I think we wanted to do something again that was collaborative, that was supportive of the just culture, and that kind of moved away from that traditional CCG provider relationship. And something that we would have done in the past probably would have been a quality visit to come in and understand what was happening. But we wanted to do something different to that, and we wanted to do something again, as I said, collaborative and supportive. So that was really our starting point, were our high number of never events. So we were really lucky in terms of the planning for this event to have Annie come down and coordinate and host this event for us. So we were very, very lucky, and we had within our ICB we've got a really great medical director who is really focused on safety, patient safety, and improving that. And I think that really helped us in terms of pulling this agenda and this workshop together. So we invited our 3 acute hospitals to come together for an event on a Friday, and we got a venue at Suffolk University. It was a great warm day, and we were right on the waterfront, and it was a really nice opportunity for everybody to come together. And we had surgical teams, so we had consultant anaesthetists, we had surgeons, we had endoscopists, patient safety experts. So we had a real mix of people that were able to get to the day and join us for a discussion. And our agenda really is as follows on the screen. So we started really with an introduction to NatSSIPs 2. We were aware that it's recently been published, so we wanted to talk everybody through the NatSSIPs 2 framework, what that looks like. We had a review of the recent never events across our system, and we asked our teams to pick 2 never events, and we assessed the impact of those never events against organisational factors that the teams felt were at play in causing those never events. And then when we did that, we did a NatSSIPs 8 people process and planning exercise for senior leaders, where we looked at kind of implementation planning. What does that look like? What does that consist of? How are we going to move forward and implement the NatSSIPs 2 agenda? And then we finished with a collective discussion of improving our cultural measures in safety across our ICS, and really a discussion on what are our next steps. What we didn't want to do was to have a workshop, discuss NatSSIPs 2, and then everybody go home and kind of put their feet up. So we wanted to actually discuss some next steps and really kind of bring the implementation of NatSSIPs to the forefront of our patient safety agenda in our ICS. So I wanted to share with you some of the discussions that came from the event, and we had a couple of teams, and we first of all asked the teams to talk about their never events and then analyse them according to organisational factors which they felt were at play or were influencing the never events. And you can see some of the things on there. So the importance of a good safety culture across the organisation was identified. The importance of involving the patient in their surgery and being a partner in promoting safety within their surgery. We discussed some restrictions during the COVID-19 pandemic which were in play, which were some causative factors of why we had some never events over the pandemic. We felt the staff might be fearful of reporting never events, so they must feel confident to speak out. We talked about process, so our teams highlighted the absence of robust counting and documentation across teams was a factor. The importance of having good induction, especially where you've got areas of high turnover. We spoke about education for staff, training teams together, which was really important for our attenders at our workshop, that we do the training together. We talked about having theatre visitors to visualise safety, scheduling last minute changes to lists, and pressure of patient throughput were identified as important risk factors. And we talked about performance, and feedback on performance was really important for our teams in sharing positive outcomes and also sharing data on safety. Some of the teams felt that they didn't necessarily see that. But I think certainly what struck me during the discussions around the organisational factors was how very quick our teams were to identify those organisational factors and the importance of them in terms of the organisational role of promoting safety. And the next part of our workshop was looking at NatSSIPs 8, really, from the CPOC framework and looking at process and planning for senior leaders. So we had a discussion amongst our teams about what they felt were important things to identify in terms of people, process and planning. So some of the things there that you can see on the screen, but again, empowering patients, considering the use of patient feedback following procedures, development of a joint group to explain the WHO checklist, and using patient safety partners to help implement the work. Our teams felt it was important to have really strong board leadership, and that leaders really held individuals in the organisation to account for safety, and very much a board approach to training involving all grades of staff and also covering the WHO checklist. Meaningful and compassionate involvement of staff in safety was something that was discussed and considered to be important. And we discussed the advantages of checklists being consistent, harmonised across departments and directorates, even across the ICS or our ICS. We spoke of digital opportunities to improve safety and capitalising on those, having an organisational standard for induction, development of patient surveys and using our patient safety partners in that work. And really, we also talked about having an emphasis on prioritising safety throughout the NHS. Generally, I think we were feeling that sometimes the NHS isn't as good as prioritising safety as it could be. So from our team discussions, and you can see those there from some of the pictures that are on the slides, those were the kind of things that came from our discussions, which I think is very, very valuable and insightful for us. So our conclusions really, and our aspirations and our next steps. And as I said, we were really lucky to have Annie come down and help us lead this event, and we were very, very conscious that we wanted to move forward and identify some next steps. So within our ICS, we feel it's important to get a proactive approach to safety as much as we can. And for some of you that are familiar with the Patient Safety Incident Response Framework and the identification of priority risks and the proactive model that is within PSERF, this seemed to be a sort of a natural fit for us to, as an ICS, to move forward and take a much more proactive rather than a reactive model to safety. We felt more observational supportive assessments to encourage good looks like was important. So there were some discussions that teams across our ICS don't necessarily know what good looks like, what the gold standard is, so we could do some work around that. We also identified that implementation of NatSSIPs 2 across all surgical specialisms, including endoscopy, was really, really important, because it was discussed during the day that there were some teams that just hadn't really done a lot of work on safety, so we identified those. We had some discussions around standardisation of documentation and guidance across our ICS. Again, making patient safety more visible. And further integration of the just culture, particularly in respect of never events and significant incidents. So that really is a summing up of our day, talking about never events, invasive procedures, and NatSSIPs 2 implementation. So we've done some promotion of the event locally, and myself and my medical director Andrew Kelso are going to get our heads together within the next couple of weeks and really start to work on our next steps. But just really thank you for the opportunity of inviting me here and discussing how we are planning to implement NatSSIPs 2 across SNE. So thank you very much.
Joe, that's fantastic, and I can't tell you how pleased I am to actually hear from outside the organisation, and something which is so much sort of cross-organisational and sort of higher up, rather than just focusing on whether someone's ticked a box in something. That's fantastic. I'm sure there'll be lots of questions about how to make that happen in every ICB across the country. You are now the lead ICB NatSSIPs person. So without further ado, there's been some questions already about team training. So I've gathered Barts has it all wrapped up, and Phil is going to tell us exactly how to do it across the country. So listen up, everybody. This is it.
Thank you, Ian, and thank you, Annie, for inviting me this evening. I'm going to share my screen. Joe, do you need to stop sharing, or am I? Sorry for the delay, everybody. Here we go. Hopefully this is it. Can you see that? I can't see it on my side yet. It's all a bit slow here. Here we go. Okay, good.
Yes.
Excellent. So again, thanks very much, Ian and Annie, for inviting me this evening to talk to you about team training. This is something that we've been going in the trust for some time. Annie has organised and run team training at the Royal London Hospital for a number of years, and has trained over 80 teams there. I've joined her for the last few of those at Whipscross and Newham before the pandemic, and we had started a programme at the Barts Heart Centre, or had planned to just before the pandemic. We have now resurrected that programme, and I'm very glad to be able to talk to you about how it looks, what it looks like. So really, the training is underpinned by NatSSIPs 2 implementation. As you can see in the organisational standards, there is a part for human factors understanding and training, and this is where it all fits in. You can see that it, on the slide on the left, It includes systems thinking, teamwork, looking at culture, psychological safety for teams, human factors, and understanding our clear processes. It is very much linked now to the patient safety syllabus and also the patient safety curriculum that was published in February. That's very much, I think, a work in progress. You know, the idea of the curriculum is to enable us to train patient safety specialists. It's not exactly clear how that's going to happen yet, but I think in this evolving situation we've got with the syllabus and the curriculum, and also now linking to PSERF, it's a really good opportunity for us to push this forward. So what is the team training objective? And one of our principal aims really is to develop strong and collegiate workforce that holds the values of safe and high quality patient care at its core, creating the conditions that enable people to be and perform at their best every day. And the people to be part is really important. This is around the personal well-being. Healthy and happy staff look after patients in a better way. So it's really much about understanding how people bring their best selves to work, and creating the conditions that enable them to perform well, the system factors. So what is team training and how can I get it? That was the question from my medical director at Barts Heart Centre. And we're able to sort of describe what team training is. It's a facilitated session that involves the whole MDT. And we should expect attendance from all key professionals and grades. And that includes managers, people that work in scheduling, healthcare support workers. So anyone involved in the team throughout the whole patient's pathway should be involved in this training. And I think it's fair to say that we should actually expect that. We have cancelled or threatened to cancel training days when we haven't got a full team, because it really isn't, you know, it doesn't hold the same value if the whole team aren't there to be engaged and understand what the processes are. But it really helps teams understand the environment and manage the environment that they work in. The most powerful part of it that we find is it builds empathy and understanding between the teams and valuing different people within the team. I think it's extremely rare that medical teams actually train together. When we come to discuss this, you know, we sometimes compare, you know, medical teams with like Formula One, for example, and the ratio of training to performance is you know, it is really, really low. We very rarely train together, but expect very high levels of clinical performance. And it's understanding how we can really work and feed off each other and encourage each other. That's really, really powerful. Embracing diversity within the team, looking for those, being curious about people that are in your team. If they ask a question, if they raise something, you know, not dismissing it, being open to comments and suggestions, and really building that kind of psychological safety within teams. We're looking to influence team behaviours, improving some behaviours, challenging less welcome behaviour, and really starting to develop a proactive safety culture within teams. And again, learning factors that affect individual team performance. You know, your own personal well-being. When might you not be at your best? You know, hungry, angry, late, tired, stressed, etc. So it's a lot of personal and people development within these sessions, and understanding and developing a team psychological safety. That we mentioned it a lot, but the ability to speak up within teams, to be encouraged. So I said previously that we've tried to base these training days now on the National Patient Safety Syllabus and Safety Curriculum, and there are four main domains within the safety curriculum, and that's around systems thinking, human factors, risk management, understanding a little bit about risk management, and safety culture. So here's the team. This is one of our cardiothoracic training days that we run recently. As I said, Annie initiated these courses way back in 2010 as part of the match training process. We have moved it to other sites within Barts Health, including Newham and Whipps Cross, across general theatres, maternity, and now very much part of the cardiac theatres and cardiology and cath labs in the Barts Heart Centre. Over 80 teams trained now across Barts Health, and I'm delighted to say that we trained our 8th team today. Annie and I had a busy day with the thoracic team this afternoon or today, so that's our 8th team at Barts. So the format of the course really is to run a number of workshops, really bringing the ideas and the knowledge really within the team kind of out into the open, so they start to understand and question, parts of their service and kind of challenge it a little bit. So we bring lectures around background knowledge. We use a little bit of human factors science to support that, and some facilitated workshop sessions, small breakout groups with a cross section of MDT. It's very important that you get the groups to separate. Every time we run a session, when all the teams walk in, they all sit within their own silos immediately. So we break them up with a little sort of icebreaker, and then don't allow them to sit back down with their own group and mix them all up. So you have very diverse groups. So we use presentations, we have entire group discussions, and I think you need to allow plenty of time that when a discussion becomes quite not heated is the wrong word. Once you start getting into a really kind of juicy conversation, you should encourage that and make sure that everyone's got an opportunity to say their piece. So we do encourage a lot of discussion, and that's where we say the gold comes from these sessions. I think it's really important to have a wingman. I have run these on my own. I'm sure Annie has as well. But when you have someone with you taking notes and actually keeping a record of a lot of the comments that are made, it's really important to give feedback at the end of the session. So yeah, we'll generate a list of main themes and actions to take into the workplace, and that's why again it's important to have managers there on the day, so they can actually hear live, if you like, the issues that are being raised. And I think then formulating an action plan at the end is really important to actually follow this through. Although some of the stuff can be really difficult and actually quite hard to implement immediately, I think if you acknowledge that it's going to be hard, but you're going to work on it, then that is accepted, if you like, by teams. So a few slides just to show you around what we kind of talk about. We've introduced the SEEPs model, which is a very versatile kind of model for looking both retrospectively and prospectively at incidents. You can use it to prospectively look at your service. So we will look at within the working system itself, concentrate a lot on people. So really the whole morning is pretty much given up to people, understanding some of the psychological factors, psychological safety, etc. When you are not at your best, communication skills, etc. So a long morning on people within the systems. Obviously, that's one of the key component really of the day is people to understand why they may behave in a certain way, and building empathy between professional groups is really powerful, really important. I think I found you make a lot of friends, and it's really nice to see that teams across professional professions working well together and really enjoying themselves for the day. So team behaviours, we've looked at the ideal exemplary team member. We've had ideal surgeon, all the traits of an ideal surgeon, the ideal manager, etc. And all of this stuff is, we collect a lot of these posters and take photos and feedback at the end with a report, including a lot of the output from the workshops. It's also important as well that you get the team members of each little group to feedback individually. It also starts to build some empathy within the group. We do focus quite a lot on civility saves lives. We do know that sometimes behaviour can be a problem, and it's something that needs to be challenged. We've mentioned that already today. We use videos. We have open conversations. and we do try and get some of this stuff in the open. I think we acknowledge it's not the easiest thing to deal with. We do talk about ways in which that you can raise concerns. I was really pleased to see stuff on the Scarlett slides earlier on about active bystanders, and I think I will be looking at how to manage disruptive behaviours, because I think as much information as we can find on this stuff would be more and more helpful for people. So we talk about communication. I've mentioned that already. The barriers to communication, how we encourage supportive behaviours across the team, and talk about situational awareness, how it's important, how we can lose it, how we can use it, how the team needs to can pull together to support each other, particularly have a surgeon who may be task focused for the moment. A surgeon who may be in charge can't be doing an operation and be looking after the team as well. So it's how does situational awareness, how does that responsibility evolve, and the sort of flattening of hierarchies at times when it's necessary, and getting people to understand how that might work. So, and then I think the afternoon we've started looking at culture. I haven't got a slide on culture, but I've noticed we've mentioned just culture earlier on. And culture is quite hard to measure, but we have kind of started to look at ways in which we can measure culture. I mean, there's a Just Culture guide that was published by MedLed, and we've used that, and it kind of creates a diamond shape, if you like, of how well your service is doing in terms of kind of safety 1 versus safety 2. Sorry to move into sort of stuff you may not have heard of, but how your service is supporting and moving from a reactive safety 1 culture into a more just culture and inclusive culture. So these are the headlines. We've got some feedback from our previous groups. My understanding of human factors has improved 75% extremely. My understanding of teamwork has improved extremely, and my understanding of civility, etc. And people genuinely feel empowered, to, I suppose, get engaged within their team and challenge stuff and become involved. And I think that's really what the team training is all about for us. So I suppose one of the problems we are facing, though, is how to make this sustainable. We are really trying to build this up from the ground up. We're making significant headway now. We've got some excellent feedback, which we've taken to our senior team. But really, it's trying to understand what this might look like in the future. So we do need funding. But I think actually what we're really talking about is building this in as business as usual for clinical teams. There's a lot of priority given now to activity, financial targets, etc., with an expectation that a lot of additional work, essential work, is just carried out by. And I think we do need to find time. So senior managers do need to find time for teams to come together to do this incredible work, along with many of the other tasks or non-clinical tasks within the service that they need to do. Building a faculty to deliver this across the organisation, something we thought about. What does it cost? What does it look like? Are we looking at developing patient safety specialists? Will there be people that can do after action reviews? And it very much seems to tie in now to the PSA project as well, which is something that we could certainly use to sort of, I suppose, ride on that wave and get team training set up as part of PSA, because we're going to need to train a lot of people around after action reviews and new skills within investigation training. So trained educators for the future, trained safety specialists, trained ergonomists, of which there aren't that many within healthcare currently. But I've mentioned building this into services as business as usual, and really trying to evolve and develop our safety culture and linking it to the patient safety curriculum, which I'm just going to pop up on the screen there so you can see what it is. If you put that into a search engine, it will come up, patient safety curriculum. There's lots of information on the curriculum and very detailed modules as to what each part of it looks like. But we focus very much on the human factors side for now. yeah, so we are very much on our way, and looking forward to the next phase of being funded and fully supported. So I'm going to stop sharing with you there, and once again, thanks very much for inviting me. Thank you.
Phil, that's fantastic, and I'm in awe. I appreciate Barts is big, but to have trained 80 teams between you is really quite some feat, and to have done it so consistently. And the fact you've even got feedback from your third team ever trained on today, so that's amazing. Well, amazing work. So we're back to Annie now. There's been a fair bit of questions in the chat, hasn't there, about checklists and other things to support what we do. So Annie, over to you, and then it's going to be questions and answers.
Can you see my slides?
Yep.
Yeah. Okay. Yes. So this was just a short, just a few resources. Oops. Can you see? Yeah. You can see. Can you see my slides?
No.
Not at the moment. Sorry, everyone. It was all going so well, the tech. Can you see?
Yes, we've got them now.
Yeah, okay, sorry. For some reason, it's not forwarding. One sec. Can you see them now?
We've got them again.
Yeah, good. I'm not going to go full screen because that seems to be causing problems. Well, maybe I'll try here. No, okay. Sorry, we'll just do it like this. Okay, so the infographics, there's one for organisational and one for sequential, which are available on the CPOC website, which you can download, laminate, and put up in all your theatre areas or invasive procedure areas. And so it just says to everyone, NatSSIPs 2 is here. So that's the first resource we really wanted to signpost you to. Within the document as well, we've got these NatSSIPs on a page, performance indicators. I know, sorry, this is really small, but again, this is in the document. And that's what we want people, when they're looking at their standards, to look at the organisational measures, specific organisational measures, and then team level measures. If you go, this is the website, CPOC Guidelines Resources, you'll see there's different, Carly's done a great job at creating different files that you can go into. And so a lot of the things people have put in the chat today, I was hoping we'd be able to add to the implementation portal, to the implant table, and so on. It is a long document, I'm sure you'll all agree. And so we decided to create these portals so that people could add stuff in. So, for example, there's a site marking table with specialty reference. So although I've said to you, you must do an arrow, there are always caveats and there are always particular. So, for example, with breast surgery, they actually do need to, for the cosmetic results, draw other lines on. And so we've discussed some of that detail during our work with talking to different specialties. The other areas, materials used for packing, some are absorbable, some are not absorbable. There's all these different brands. So we've tried to bring some of that together, and that's all in the portal. Also examples of checklists, and we'd love it if everyone could send in their checklists so that we've got an examples of different checklists. And some of the stuff in the chat is exactly what we want in here, and things like count competency frameworks. I also wanted to point this out, that was a collaboration. So Nigel Roberts, who's been doing a PhD, who's an ODP, contacted me and said he wanted to adapt the NatSSIPs 8 sequential steps, and then he's published this as part of his PhD, but that we're really open to people getting involved and adapting things. And so you can see this includes where the wrong site, wrong implant, or retained foreign object is, never events. And so we really want people to take it, use it, adapt. And so that's more of a pathway document that's also available. I've just thrown this in because we were talking about team brief. This is what we had a QI group that developed this multidisciplinary team brief performer. And you'll see that it encourages everyone to introduce themselves. It also has a how's the team feeling, the green, orange and red, and actually people really like that, a kind of RAG rating. So, you know, we recently, someone's dog died and they said, actually, I'm feeling really sad. And then the whole team knows, be nice to them today. It also includes, you'll see a QR code for doing a Greatix. So if you see something great, Greatix it, so it's encouraging that learning from excellence. And it has other issues around breaks, staffing and feedback. And our teams have found this really useful. I wanted to show you some of the checklists that we've developed just to make the point around standardization and harmonization. So all of our checklists, of which we have about 30. So in a dedicated specialist area, we have dedicated checklists, so maternity, interventional radiology, for example. But you can see that the questions are consistent, the wording, the look is the same. We've actually made them portrait, and as we go digital, we've got posters on the wall of these checklists, and there is actually a minor one there where you can see that you know, there's a timeout and a sign out, and we don't expect necessarily the other steps. And so I just wanted to show you examples of different checklists and how we've adapted them. Also within the timeout, you'll see that there's an opportunity for every member of the team to speak. And I think that's really important to encourage that team communication. Going back to what Phil was saying, the link between the team training and the NatSSIPs we really make within the course. So we say, you know, how do you communicate? And then it all comes out. They say, well, actually, we have the team brief. And then we talk about the team brief, you know, and the different steps within the pathway where they communicate. How do they maintain situational awareness? Well, again, you know, at timeout, there's various questions that highlight the situation, and there may be pause points within the surgery, or moments, stop moments, or safe moments, as Mark Rigby's put in his poster, where the team stops and gets the situation awareness back. So I think the link between the team training and the NatSSIPs is really easy to make. It all comes out when you're working with invasive teams. We've adapted the prep, stop, block guidance to create a box where the needles are kept. So if you look at the RA UK video, they say to not hand the needle until the checks are done, and we've created a box to sort of help us, and that's been kind of allowed as an adaptation, and we found this really works well for us. We had a number of wrong site blocks. We were talking about items deliberately retained, and this is what we've used, this sticker that goes in the notes, and you can see we've also got a number in and out because we had issues around that, but I just wanted to show you that, and the wristband. However, as I did say before, we do want to make this digital. So this is a sticker that goes in the care plan at the moment. I just wanted to, while I'm on air, this is a podcast I've recently recorded about learning from excellence. If you want to zap that, something you might want to listen to at a later date. And that's it in terms of resources, but I'm hoping we can build more resources on the CPOC and patient safety learning websites so that we can see what other people are doing. And I do find when I go to other hospitals, so recently went up to Lister and had a look at their checklist, for example. You see that there's different stuff all around, and it's really interesting to see how different people are doing it. And I think collaboration is definitely the way forward, which is why we're all here today. Thank you.
Annie, thank you very much. What an amazing set of talks. So there's been loads of stuff going in the chat. I'm going to try and give you a little bit of a break because you've done a lot. You've given us so much stuff. So I'm going to come to Phil. I'm intrigued. With your team training, you said you sort of try and find out what's going on with your teams. What are the common themes? Rather than you sort of, I'm sure you've got top down. We are going to tell you about this, that, and the other. But what are you said that the teams sort of are encouraged to tell you about their own problems. apart from the fact that the computer doesn't work, are there any common themes that come across which might be relevant to other people or peculiar to Barts?
No, I think one of the most powerful ones is really about resources. Often around adequate skill mix, adequate staffing to perform the tasks themselves. When people are short-staffed, there's a lot of stress around getting the work done. Often, I think the requirement for activity stays the same, almost regardless of whether you have the right number of staff or not. And I think within healthcare, we're often expected to fly, if you like, if that's the right term, with inadequate resources. And one of the most important things to come out recently is procurement and supplies issues across the board. When you simply can't get the equipment that you need to perform the task, or it's in very short supply, or you're trying to do workarounds with kit you're not familiar with. And these are the pressures that we've found that people are really highlighting at the moment, and it really adds to the cognitive loading for the day. If you're having to, kind of write a new SOP, if you like, on the hoof around a new piece of kit that's been, you have to use today because the one you normally use isn't available. That's really, really cognitively demanding, and I think trying to recognise some of that is really important. A good way of doing this is using the CPOC model. What we actually do is use the CPOC model and ask people to identify, performance influencing factors within each kind of area. So organizational, for example, maybe climate, tasks. We do a lot of work on people, like I've said, and we start to ask them to look at within their service what influencing factors are present, and then really get them to put them in a hierarchy. So almost to say, right, if you had a chance to if you wanted to escalate one or two of these issues to management today, what would they be? And then kind of put them in a hierarchy of what needs to be fixed. But also really importantly, Ian, is to say, this is not all bad. Let's have some appreciative inquiry as well, because there will be stuff in your department that's good. And in the interest of safety too, and understanding what's working well, is identifying what is good, in your service, what you should do more of, and how that could be further supported. So we kind of use those influencing factors and can almost by stealth get teams to sort of do a prospective risk analysis of their service, by taking them leading them through the CPOC model. And get them to identify those issues. Which is kind of a small part of it, but yeah, that's how we kind of setting things up at the moment.
Thanks, Phil. Really interesting about the whole workarounds thing, that we're very good at being dynamic. We're not so good at being a bit boring and sorting out so actually we have the right kit in the right place at the right time. Joe, I'm fascinated the fact that if Joe's still here, I think he is, you got everybody together from your ICB. How did you get everyone to buy in?
Determination, perseverance, encouragement. I don't think there's any magic solution that I can kind of offer, really. I think throwing in a good lunch helps as well. But I think we were just really focusing on what we felt was the issues and the risks, are our large number of never events, repeated themes that were seen, and this is what we wanted to do to kind of help support and make some change as we came together through as we are now as ICBs and ICSs rather than CCGs and providers.
That's fantastic. I mean, really interested to see whether that's followed through. So I suspect your ICB might be ahead of the game in that sense, rather than just being reactive to what's happening. And again, as I put in the chat, I think it's, for me, having done the NatSSIPs work, the fact that you are bringing out the high level problems rather than the sort of the low level stuff is really encouraging. Because again, for those of you, I suspect everyone's read it, but we try very hard in NatSIPs to talk about the importance of organisational stuff. And it's interesting, there's been some comments in the chat earlier about at least one organisation struggling to get leadership at the top of the organisation. And that's, if that leadership isn't there, we can we can spend as long as we want talking about whether someone has filled in the checklist or done the briefing properly, but that won't lead to a good culture. And so Helen snuck in a question, which is very cheeky from a speaker to sneak in a question. Which was, I'm trying to basically, is CQC interested? I can't speak for CQC because I'm not the CQC, but I suspect the answer is they should be. This is a national document, and they will know about it. There are aspects of NatSIPs which we've directly addressed to CQC. We want CQC to understand what it means to work in an invasive procedure environment, and that it's not about going around with a clipboard watching whether people are, or worse still, just looking at someone's documentation. So yes, they should be interested, but it'll be interesting, Helen, with your sort of connections in patient safety learning, with the conversations you have as to where they as to how they view that, and how much it's on their radar. We can tell them, and they do know, but whether individual inspectors pick it up, I don't know.
If I could help answer my own question. I mean, I've started speaking to some of the head of regulation, patient safety regulation and policy at CQC about their new framework, and I'm going to write to them because we had a very successful conversation with them. But I was just thinking about how you get organisational leaders to pay attention to this, and certainly it's a bit of a it's more stick than carrot, but if CQC are interested, then it might get your own organisational leaders a bit more engaged. But I'm due to write them with a summary of, as I say, a very good conversation because of the work we're doing on patient safety standards and the value that they see that organisational approach. But I'll follow up and add NatSIPs into it. So I'll make that connection and maybe link in with you, Iain and Annie, if they want to follow that up. Yeah.
That's brilliant. Thanks, Helen. And always good when someone answers their own question. Excellent. So Annie, the perennial question that's coming up around sort of LOCSIPs and checklists, and I think you said you had 47 checklists. I can't remember the exact number, but
30.
30. Which is still quite a big number, but you don't have one. So how did you find that balance of getting it matched to the specialty versus everybody's specialty saying it's Thursday and I do it this way, so I want a new checklist?
So it's very difficult. We had the rule. We have a NatSIPs committee, and the rule was at the time, that if you're in a specialty area, so maternity has their own checklist because there aren't other procedures going on there. Where we ran into difficulty is where we had a pain checklist, and then some pain procedures were being done in the main theatres, and they used the wrong checklist. That's where the problems start. And I think clearly, we have a main theatre with 12 theatres and a day surgery where it's not really day surgery anymore, but 6 theatres below. They all use the major checklist, no questions asked. That's what happens there. So the dedicated areas, like we have an IVF checklist where they only do IVF and they use a special checklist. So it's always been a bit of a tension, but they all look the same. They have the same questions and there are minor variations. When I first started it, every checklist had different wording, different language, different order, different look, very confusing. So I think standardizing and harmonizing is the first thing to do. I did put in the chat, but I think as we go digital, this may all change, because if you could have a drop down checklist for each procedure if you wanted, with digitalization, because there are checks that people do want, but that would be a huge piece of work. But the order is probably set already. But I think digitalization does offer the opportunity for more specialist checklists. But as we've said in the chat, less is more. Keep it simple. Don't overburden teams. Associate it with risk. You know, if you ask everyone a question about, we had a checklist that had CJD in every checklist, you know, it's overburdening the team with too many questions, and you know, we understand human factors, their bandwidth will be reduced by having too many questions. Their attention will be reduced because they feel it's not relevant. And so, as I think someone else put in the chat, working with the teams to work out what's important, using your governance to influence what checks need to be done. I mean, one of the checks that we've added to every checklist that's been a huge success is at the end, should anyone talk to the patient or family? And so many surgeons have said to me, actually, you know, you've been task focused, and just that reminder at the end that there's a patient and a family, someone waiting outside worrying, they find really helpful. And you know, I think so there are, and that's reduced complaints to, you know, people waiting for hours with no information. So stuff like that. But they're not perfect, and I get lots of requests for adaptations, and it could go on and on and on. And I think you also have to, if you keep it simple, you also say no sometimes, and you review them, but you can't be reviewing them every week. It becomes too much of a burden.
Thanks, Annie. And that actually links to a point which someone popped in the chat around. There's a question around sort of combining sign and time out for, I think, for cataracts. But that concept of, I like to think we moved on, because in terms of, rather than saying we must implement a checklist and everything else must follow a checklist, or the way the checklist is designed, actually take the stepping back and thinking about what is the safest and most efficient way to administer the process that is going to be happening. Then the checklist should be an opportunity to do the checks along the way, rather than we've got a checklist, we must adapt our process to the checklist. And that's where having the experts in the room these aren't necessarily easy things to do. I think really come through. I'm just intrigued, actually. I'm going to ask the question, see what people pop in the chat, or you can put your things up. At least one person said they basically haven't got a lead for NatSSIPs, a sort of senior lead for NatSSIPs in their trust. This is always risky doing audience participation on a webinar. So I guess stick your thumbs up if you think you have got a senior lead. By a senior lead, I mean someone who's not necessarily the board level lead, but a sort of senior operational lead for your trust. The person that you can go, that's the person that is Dr. or Mrs. or Miss whatever NatSSIPs for your trust. Anybody got one? Anyone not, or anybody prepared to say they haven't got one in their trust? You're supposed to have one. People were sticking their hand up saying yes, they've got them. I'm intrigued to know what only just means. Someone clinging on by the fingertips, or only just got one. So I think that'd be fair to say. Helen, you can certainly take that one away. That we there's lots of thumbs up, which is good, and there's quite a lot of not sure, which is honest and that's real and that's important. I think to have that. And there's a definite no from there. So Annie, you might need to take on the Chelsea and Westminster by the looks of it. So right. Before we go, because time is marching on, I haven't warned about this. I'm gonna they're all looking at me again. Who can I get this question? Susanna. you're a patient, so you've clearly you've done a huge amount of work with safety and healthcare, but you listened to everyone's talks, you've seen what's in the chat. As a patient looking onto this, not as a healthcare professional, what's your perception of the good bits, the bad bits, the missing bits? Where could we be stronger? You want to get the last word. I'm going to shut up when you stop talking.
Oh, I love it when you put me on the spot. Okay, well, the good bits is that evidently from the involvement today and the engagement today, people really care and want to see this, and they want to manage a really challenging environment and try to ensure safe care. And, you know, my entire gratitude and appreciation to everybody who's listening today. So thank you all very, very much. I love seeing both Philip and Joe's presentations about implementation, because obviously we've been involved writing it, but it is really fantastic to see how it's being implemented in the training and for that example to be available to others. The worrying bit is seeing in the chat really big trusts without clear leadership on it, which I think is pretty scary. NatSSIPs has been around for quite a long time now. So that's where, so many of our conversations, okay, you've asked me with my patient hat on, but I mean, so many of our conversations when we were in the process of looking at NatSSIPs kept coming back to the fact that we needed the engagement at a really senior level. And I think that just comes back again today. And that is, Joe's nodding. It's so clear, isn't it, that this is almost the biggest bone of contention, is it's getting the really senior leadership on board to make time for it, to enable the training, because actually people want help and they want to be practicing safe care, and that will really help everybody if we can ensure it. That wasn't really a patient answer. I mean, my patient answer is obviously I hope not to clog up using healthcare anytime soon for all of your benefits.
Susanna, that was fantastic. I think you've put it there. And so it is dead on past. How's that? Perfect timing. So can I say thank you to, firstly, all the speakers for giving up your time and your energy and all the amazing work that you've been doing to be allowed to do that. And to Helen and Mark and the rest of the team at Patient Safety Learning for hosting us tonight. Send all your stuff to Helen. She's desperate to have more work to do to put stuff on the chat, so on the blogs and things. So everything you want to share, send to Helen, and we hopefully will see you at one of these events in the new.